Good evening, and welcome to this webinar about research into the development of esophageal cancer and the importance of early detection in promoting successful treatment. This Q&A event has been organised by the National Institute for Health and Care Research, or NIHR for short, which is a government-funded body supporting research in the NHS, public health and social care. If you'd like to know more about their work and are interested in taking part in research studies, do visit the Be Part of Research website, where there's lots of information. You don't need to have a medical condition to take part in many of the studies. Healthy volunteers are extremely welcome. My name is Liz Chipchase, and I'm a very enthusiastic supporter of involvement in research because 6 years ago, my GP invited me to take part in a study called BEST3. This was designed to see whether the cytosponge, or as it was more commonly called then, the pill on a string, could detect early changes in the cells lining the esophagus as efficiently as the current standard examination using an endoscope. A proportion of patients showing these early changes, which is a condition known as Barrett's esophagus, may go on to develop cancer. I was invited onto the trial because I'd been treated for acid reflux for about 40 years, but I was confident that I was fit and well and would provide a negative result. In fact, the test came back as positive, and further examination showed that I did have esophageal cancer. But thanks to taking part in that trial, it had been found at an early stage and could be removed by a simple procedure. At least it was simple for me. I'm sure it wasn't so simple for the endoscopist, but a procedure called endoscopic mucosal resection. My brush with the cytosponge means that I'm able to be here tonight to put your questions to the person who thought up this ingenious device, Professor Rebecca Fitzgerald. Rebecca is Professor of Cancer Prevention at the University of Cambridge and Director of the Early Cancer Institute, where she leads a team looking at groundbreaking ways of improving outcomes for esophageal cancer patients through earlier diagnosis. Just before going to Rebecca, there are a few housekeeping matters. This event is being recorded and you will be sent a copy of the recording. Please ensure you keep your camera and microphone switched off. Thank you for all of you who've already put in questions. And if you want to ask a question in the course of the webinar, please post it in the chat and we'll do our best to get it answered. But please be aware, we can't answer questions about individual cases. And if you have any concerns about your health, do consult your doctor or medical team. Before I start with the first question, Rebecca, would you like to tell us a little bit about yourself and the work you're doing on esophageal cancer?
Yes, well, thank you, Liz, very much for that introduction, and fantastic to see you all joining this webinar. It's really important, I think, when we have concerns and questions to be able to get together to share those questions, and Liz and myself are going to do our very best to answer them, and I can say we've got some very interesting questions that you sent in advance. As Liz says, I'm based at the University of Cambridge. I'm a gastroenterologist. I've been practicing for in Cambridge for 22 years. I qualified quite a lot longer ago than that. And it was early in my medical training in the early 1990s that I came across a patient with a very advanced stage of esophageal cancer. And when we were discussing the case on the ward round, the consultant explained to me that they had Barrett's esophagus that they could see alongside the cancer. And that this was the pre-malignant stage or the pre-cancer stage. So I remember asking the consultant, well, did we know that they had this condition? So why couldn't we do something about it? And they said, no, unfortunately, we didn't know they had the condition. And anyway, if we know they've got Barrett's esophagus, and this was in the 1990s, we really just monitor it until cancer's there. And that was before we had endoscopic therapy, and the only thing we could offer patients was esophagectomy, even if we thought the risks were very high of it transforming to cancer and the early cancer stages were there. We didn't have the endoscopic resection, Liz, that you had. So how times have changed. And it was that conversation that really got me inspired to think about what we could do to better understand the pre-cancer stages that lead on to this cancer, and then what we could do about it to find the patients with that pre-cancer condition and to prevent them getting cancer. So that has been very much my inspiration, and the work that me and the many people working with the team have been striving to do over the past 20 years or so ago. As Liz said, I did develop the cytosponge with my team, and we've got patents on the subject, and I formed a company, Cited, to process the sponge. So you should bear in mind, I'm passionate about this subject, and I'm not unbiased. We all have our biases, but I have developed that technology, so I am biased in that respect. So Liz, shall we go on to the questions now?
Right, yes, I'll put the first one to you. It's actually a lot of people sent in questions asking whether a wide range of different factors might cause esophageal cancer. So I'll put them all together into one question, and perhaps you can go through and say which ones are the most important. So do factors that cause esophageal cancer include acid reflux, prescribed drugs, especially things like alendronic acid, residuate, and Grazax? What about eating acidic foods and drinking very hot liquids, smoking, and some health conditions that can damage the throat, for example, bulimia and the after effects of COVID? So can you comment on how important these all are?
Yes, thank you, Liz. It's quite a comprehensive list. So I should just say that there are two main types of cancer of the esophagus. One is squamous cancer of the esophagus, which is globally the most common cancer, but actually that's been declining in the UK and in the Western world. And then adenocarcinoma, which is the type associated with Barrett's. Some of the risk factors are shared, but there are also differences. So when we think about the risk factors for esophageal cancer, it does depend which type we're talking about. So for the Barrett's adenocarcinoma, then acid reflux, particularly acid reflux that's been occurring over many years, chronic acid reflux is a significant risk factor. And we've known about this for some years now. I remember reading the really groundbreaking evidence for this on a very big trial reported from Sweden in the 1990s, 1999. And that really was the first big definitive evidence that showed the link with a substantial increased risk in people that had chronic heartburn. Now, people always wonder what chronic means. How long do you have to have had heartburn for it to increase your risk? So we're not talking about very occasional, but if you're regularly having to take, most weeks, take some medication for acid reflux, then that's a risk factor. Sometimes acid reflux can happen without you knowing about it. That's also a risk factor. So that's more problematic because you don't know you're having it. The drugs, these are all drugs used for osteoporosis. They're quite sort of corrosive. So if they don't go down, when you swallow them, if they stick around in the esophagus a bit and you don't swallow them well, sitting up with a good glass of water and they kind of stick onto the esophagus, that can really cause a lot of inflammation and irritation, which isn't a good idea. So my main thing about these drugs is to make sure you really take them with a good gulp of water. Now, there has been quite a lot of discussion about whether these drugs increase the risk of cancer. And I did take the opportunity just to look up the data, the latest data, so I could give you a good, fulsome answer on this. And there's been a very nice study which combined all the evidence to date across 11 studies to really try and look at this in some detail, take into account the biases in some of the reported studies. And when they combined all the studies together, and they did what they call a meta-analysis, they found that overall there was no increased risk of esophageal cancer from these drugs. So I think, from that evidence as presented, which is now on quite a goodly number of patients over a number of years, I think we can be fairly confident that these drugs are not bad in terms of causing cancer. But as I say, they can be quite irritant to the esophagus, so drink them with a good gulp of water. But if you need them for osteoporosis, it's always a matter of any drugs weighing up the harms and benefits. And I would say, take them if you need them. Acidic foods can be irritating and exacerbate heartburn. So I would avoid any sort of foods that exacerbate heartburn. But I don't think we know it's very difficult to measure how food impacts cancer risk, but I'm not sure that eating acidic foods per se causes cancer, but it can exacerbate the reflux. Now, drinking very hot drinks, that's associated with the other type of cancer, the squamous cell cancer. And so there are some parts of the world where it's customary to drink really scalding hot tea. In northern Iran, for example, I went there to do a study, and that is, a lot of these things act via causing inflammation and damage to the esophagus. And you can imagine that if you drink scalding hot tea, that may cause quite a lot of inflammation and damage. And there is a link between that and squamous cancer of the esophagus. Smoking, generally bad for your health, so always one to try and reduce. Smoking is associated, it's a moderate risk factor for adenocarcinoma and a strong risk factor for the squamous cancer. Squamous cancers tend to occur nearer the top of the esophagus, so you can imagine that's where, if you're smoking, more smoke will be inhaled to the top of your gullet than the bottom. What about vaping? We don't really have any data on vaping yet. Bulimia, so making yourself sick after meals, there is a little bit of data on that. The numbers are rather small, but again, it may not be very kind to the esophagus because you've got acid and bile coming up from the stomach into the lower esophagus. So again, it can cause inflammation. There's not strong evidence to link that with cancer, but none of these things that cause inflammation are good for your esophageal health. So COVID, of course, it's early days in terms of us getting follow-up for COVID, but I'm not aware of any links between COVID and cancer of the esophagus, or indeed really with reflux. It can affect the voice, but that's independent, and we'll come a bit later on, I think, to hoarse voice and cancer of the esophagus. Liz, you noticed when you looked at this list that obesity wasn't on there.
That's right, and somebody has asked a question in the chat about obesity, so you can talk about that now too. Very
good, because obesity is quite a strong risk factor for the adenocarcinoma. And the mechanism for that is probably that because if you're overweight, that puts some more strain on the diaphragm and you're more likely to get reflux of acid and bile coming up. So oftentimes these risk factors all, work through kind of a common pathway for the adenocarcinoma, increasing reflux, increasing inflammation.
Right. Shall we move on to the next question, which is relevant to me because I've got a hiatus hernia. And the question is a hiatus hernia correlated with developing Barrett's or esophageal cancer? And are there any developments in treating hiatal hernias to reduce any risk that they present?
Yes. So I would say that it's unusual to have Barrett's esophagus without having a hiatus hernia. So nearly all patients with Barrett's will have a hiatus hernia. Can be small, can be large. But what a hiatus hernia means is when the stomach is slipping up through the diaphragm. And what that then means is that your diaphragm is a muscle, and if that's not aligned with the bottom of the esophagus where there's a little sort of internal valve, then you have a weakness there and you lose some of the normal defense mechanisms, and acid and bile will start to come up more easily. So a hiatus hernia is correlated with reflux, correlated with developing Barrett's, and therefore, because I've told you that all those things increase the risk of esophageal cancer, these things are all linked. But on the other hand, I should say that there are millions of people out there who have hiatus hernia and have some reflux that don't have Barrett's and that don't have an increased risk of esophageal cancer. So these things come to, it's not everyone with reflux will get esophageal cancer. Not everyone with a hiatus hernia will have bad inflammation. So it is all a matter of degrees. But yes, it's a risk factor for reflux. Most people with Barrett's have a hernia. We tend to treat Barrett's for the symptoms of heartburn, so with acid suppressants, and that will help calm the inflammation as well. Sometimes we treat the hiatus hernia itself to try and reduce the reflux more definitively. That's particularly useful if you can't tolerate these medicines like omeprazole, pantoprazole. Some people just get a lot of side effects, so then an operation can be helpful. Or if the medication just isn't very effective, which we also see that the medication is generally effective, but not always. So sometimes then an operation is helpful. Are there non-surgical endoscopic treatments? So there are a number of ways you can try to reduce reflux without an operation. The operation is usually a wrap, and this is called a Nissen fundoplication. Fairly straightforward operation, but doesn't necessarily hold for life. So patients may have to have a redo sometime in the future, or you may have to go on medicines. Can you do it down the endoscope by a sort of laser type of treatment causing scarring, or putting some stitches in there, or a material that bulks out the lower esophagus and sort of reinstates the valve? There are a number of different endoscopy treatments. I don't think we've got time to go through all of them, Liz, but I would say there are very good information on the NICE website and the Heartburn HC UK website, for example, that goes through some of these in turn. But I would make sure, as new fancy treatments come along, that you get good advice from someone who's really looked at the evidence, and you ask them how many procedures have been done worldwide, how many have you done, what's the success rate, because they're not all equally as good or equally as proven. What I can say is the surgery is, we've got a lot of data on the surgery, and if you have a good surgeon who does it well, that's good. Some of the endoscopy treatments may be okay, but check it out first before you jump into it. And for many patients, the medication is just fine to suppress the acid.
So then the next question is a fairly general one about genetic factors in esophageal cancer. Many people are naturally concerned that if they have a parent with Barrett's esophagus or a parent who had esophageal cancer, so is there a genetic factor?
Yes, so this is a good question, and there are genetic factors. It tends to be factors rather than one factor. So there isn't a esophageal cancer gene that we have discovered that's a single gene. Unlike, for example, breast cancer, we know that the BRCA mutations in the BRCA gene are passed down families, and it's a mutation in that single gene, or a gene fault in that single gene, that will predispose you, and then we take preventative action. We don't have such a gene for esophageal cancer. The studies looking for this now are quite large, amounting to hundreds of thousands of patients. So it's quite likely that there isn't really a gene fault that we can systematically test for. It may be different in some families, or it may be multiple genes. So if you have a family history, that is, although we can't measure which particular gene fault, we know that a family history is important. And if you have a family history of Barrett's or esophageal cancer, then obviously the more relatives affected, the more significant that family history is. And I would recommend that relatives get checked out with an endoscopy or another screening test. We'll come on to those in a minute, especially if they have reflux. For most patients, they don't have a family history and they develop Barrett's or esophageal cancer. We don't really know why. For all of us, our combination of genes that we inherit from our parents does have an effect on which diseases we're susceptible to. And even, esophageal cancer with no family history, it's probably the combination of genes that we were dealt, that we inherited, combined with risk factors from our lifestyle, that together add up to make us more susceptible. So for every patient with esophageal cancer, there's probably a bit of a genetic component, but not one we can measure. And if you have a family history, then I would get checked out.
Fine, thank you. Then the next set of questions is about screening for Barrett's. And again, I've compressed several questions into one, so it's a long one. If you're prescribed PPI medication, should you be routinely screened for Barrett's? And if so, how often? And if you're found to have Barrett's, how can it be managed? And how is it monitored? And then there are some more specific questions about the cytosponge test, which maybe you could answer the first two.
Yeah, let's come back to those.
Yeah,
I think that's a good idea. So most people with reflux, just a bit of background for this, because it's really a question close to my heart and close to Liz's heart, as she said at the beginning. Most people with heartburn never have an endoscopy or any investigation to see if they've got Barrett's. That's because most of us don't necessarily, many people, about 10% of the adult population, suffer from heartburn. They don't really think it's anything to worry about or to go and seek medical help about. And if you can imagine starting to endoscope everybody with a little bit of whiff of heartburn, our NHS will probably start really, struggling to cope with that demand. And it's probably not necessary, because most people, as we said earlier, with heartburn won't have Barrett's. So we need to think about what, the other risk factors that people have, and then to perhaps have simpler tests to look for it without having to endoscope everyone. So one of the questions is, well, who should you test? If we're saying heartburn significant, is that everybody with a bit of heartburn? How much heartburn do you have to have? So we know that older age is a risk factor. And if you're prescribed medication for your heartburn, then it probably is bad enough that it's worrisome. So that's a very good proxy that we've used in all of our screening trials when we're selecting the population at risk, so to speak, is to select older people, I'll come back to that in a minute, and people who are on medication, usually proton pump inhibitors for heartburn, because that means that they are more at risk. Now, men are at greater risk than women. Actually, we didn't talk about that in our earlier risk factors list, but for adenocarcinoma and Barrett's, men are at substantially higher risk than women. And so in our next screening trial, we're going to recruit the men at a younger age than the women. So the men will be 55 and over, and the women will be 65 and over. So it's all about those risk factors, and then deciding, who you should test, how you should test them, and as you say, the question says how often. So it's quite complicated, this. So the first bit is who to test. So I think if you're on medication, yes, that probably is sufficient to consider getting an investigation, depending on your age. If you're very young, unless you've got a family history, it's probably not needed. The gold standard is endoscopy, but we'll get back to the new tests coming available in a minute. And that, as a one-off test, is probably the most valuable thing. Whether you should have it every 5 years or every 10 years, to be honest, we don't really know yet. And if we get to the point of rolling this out as a national programme, that's something we'll have to think about, is how often it would be and what the cost and logistic implications of that are. But I think in the first instance, a single examination on someone who's older age and on medication is probably a good idea. Now, then, if you're found to have Barrett's, how can it be managed? I think that was the next question, Liz. So, the diagnosis of Barrett's needs to be a proper one, because sometimes people get labelled as Barrett's and it's really just a hiatus hernia. So sometimes people contact me and say, well, one doctor said I have Barrett's and another one said I didn't. And that's because it can be subtle. If it's a longer segment, it's easy, but it can be subtle. If you've got proper Barrett's so the endoscopist can see it, and the biopsies show the cell changes, particularly associated with a risk of cancer called intestinal metaplasia, then it should be monitored. And the monitor, the gold standard monitoring is with endoscopy. How often you have it depends on how long the segment is in your esophagus. It could be anything from 1 centimetre to 15 or even 20 centimetres. And obviously, the longer it is, the greater the risk. So we, would look more often. And also what the biopsies show, and whether there's any evidence of the cell changes that we call dysplasia as it starts to evolve towards a cancer. So we use those pieces of information to decide how often it's monitored. And we're starting to think about how we can move towards using tests like cytosponge or capsule sponge to also monitor as well as diagnose. Because if we want to test a lot more patients in the first place and then be monitoring more patients, we need to be doing it more simply and in GP surgeries. So that's all I hope for the future, and it's being piloted in the NHS now. So then do you want to move on to the cytosponge, Liz? Because I think we've kind of got there, haven't we?
Yes. So the questions we actually had about cytosponge were how widely is the testing available? And then there was a question about, can you use the test for other types of cancer? And do you screen for Helicobacter pylori? And my favourite question, I think, is, and I'm sure this will appeal to all patients, will endoscopies become a thing of the past? And are there any developments for making them easier for patients?
Yes. So maybe first I should, just for anyone on the call that doesn't really know what we're talking about with cytosponge, I'll just briefly describe it. So capsule sponge is a kind of generic way of describing it. So it's a little capsule. I've got one, but I don't know if you can see it. Can you see that, Liz, if I hold it up?
Just about, yes.
Yeah?
Yes.
So the capsule attached to a thread. So you swallow the capsule down, it goes to the top of the stomach, and then the capsule dissolves. We leave it for 7 minutes, and then out pops this larger sponge. I don't know if you can see that. And then the nurse simply pulls it out over a few seconds. And we collect a big cell sample, so over 1 million cells, as it's pulled out from the top of the stomach along the length of the esophagus. So it's really a cell sampling device that can be done very simply in the GP surgery. You don't need to be sedated or anything, you just swallow it with water sitting up. And then we send that sponge sample in a pot to a laboratory, and they take all the cells off the sponge, they spin them off, and then they make the cells into a kind of mass, so they sort of clot them together so that they don't all spread. And that way we can put them into paraffin, which is what laboratories routinely used to look at samples, so we can cut very thin slices and then stain them with different antibodies. And we've made the laboratory tests to stain for antibodies to look for whether Barrett's is there and how advanced the Barrett's is and whether it's progressing to cancer. So we stain for a test called TFF3, which looks for the Barrett cells, and P53, which is a cancer test. And we also look at cell shape and things using the H&E stain. So that's what the test is. So we've done 3 trials so far, the best trials 1, 2, and 3. And that was one of the trials that Liz took part in. And then when COVID happened, endoscopy was really shut down, except for the most urgent cases, because doctors are diverted to look after COVID cases, and also because endoscopy spreads aerosols, and there was a lot of concern about the virus spreading through endoscopy. So we started rolling it out in the NHS in Scotland first, and then in NHS England. And to date, over 16,000 tests have been performed using this test. Now, in COVID, we used it slightly differently than screening. So we'd really developed the tests to screen for Barrett's. But in COVID, because of the endoscopy waiting lists, we were using it to test people who were on the endoscopy waiting list with reflux. So it's a type of screening, but the GPs had referred them in for an endoscopy rather than us taking people off the GP drug prescribing list and finding all the people on medication for heartburn and offering it to them. These are the people that the GP had actually referred. And we were also using it to monitor patients with Barrett's. And that work is still going on across Scotland and England, and we're monitoring the results. So it's available in quite a few hospitals now across in Ireland, Northern Ireland, Scotland and England. The data is all being evaluated. And that's, as I say, for people with reflux symptoms and people having monitoring for their Barrett's. What we're about to do is start a new trial, a very exciting trial called BEST 4, which will be the last BEST trial, because what the UK are considering is, should this be a national screening programme? So not just for people on endoscopy waiting lists, but for people that aren't going to go and see the doctor otherwise, that we would invite, like you have an invitation for a mammogram or a cervical smear or a colon screen, to be invited to come and have the test. So that requires the sort of level of evidence to see whether it actually reduces morbidity. So the kinds of, do you have to have chemotherapy and esophagectomy, or can we actually improve how early it's diagnosed so we can treat it endoscopically? And can we also reduce the deaths from esophageal cancer? So to do that for BEST 4, we're going to randomize 120,000 patients. So it's a huge trial that's about to start in the new year. So the test may be available near to you, and if not, if you contacted us, we would be able to tell you where it is available and also let you know about the trials that are ongoing. Can it be used for other types of cancer? So we are, you can measure anything in the esophagus with this device because it simply collects the cells. So if you then analyze the cells in the right way, you can look for inflammation. You can look for Helicobacter pylori if you want to. You can look for a condition called eosinophilic esophagitis, which is a kind of allergy. And you can also look for squamous cancer of the esophagus, which is the other type of cancer we discussed earlier. So we're working on the tests in the lab to enable us to do those other things. Now, this wouldn't be the way you would normally screen for Helicobacter pylori, so I should just make it clear. If you're going to have a H. pylori test, if you had indigestion and tummy pain and the GP thought you should be tested for H. pylori, you wouldn't do a cytosponge really, because that's really an esophagus test. You would do a simple blood test or a stool test, and then we do a breath test to check it's gone away for Helicobacter. But as it samples the top of the stomach, and sometimes the Helicobacter pylori lives there, especially if you're on medication for acid, then if we see it in the sponge, we would comment on that when it's reported. Will endoscopies become a thing of the past? Well, we need endoscopy because that's how we treat the cancer. But what I would hope is that we would be, in an ideal world, we should be testing far more people with a simpler test, because most people who are at risk never get to know until, for the small portion of them that do get cancer, they get it and it's diagnosed late. So we need to be doing a triage and testing far more people. But then being thoughtful about who needs that endoscopy, because as you say, Liz, many patients, be great to avoid endoscopy. So you only want to be doing the endoscopy if you're pretty sure there's Barrett's there and you want to confirm it, or if you need to treat. So I would hope we'd be doing much more capsule sponge type of tests to find the Barrett's in the first place, and then to monitor the low risk Barrett's. And then really focus down the endoscopies on the people that need them most. And the other thing that could do is mean that endoscopy units, instead of doing zillions and zillions of endoscopies where we don't find anything, we focus on the endoscopies that are really needed, and it means we're doing fewer. The experts can do them for Barrett's, who really know about Barrett's, who care about Barrett's, and make sure they're really taking all the biopsies, having a very careful look to find the subtle dysplasia and things, so we can improve the quality of the average endoscopy as well. And there may be other tests that come along that also mean that we don't need to do endoscopy, like breath tests or multi-cancer blood tests. So I think there are a whole load of research programs going on to try and think how we detect esophageal cancer earlier without relying on endoscopy.
I do get the impression that endoscopes have got slightly narrower as time has gone on.
Yes.
Because 40 years ago,
you were right, Liz. Yeah, I mean, in the old days, we had no video attached to them. We used to look down the endoscope. It was a very bad view. And they've got more sophisticated. The optics have improved considerably because the cameras is so much more sophisticated, and the technology has improved. So we can see it much, much more detail now when we do the endoscopy. And because the camera's been miniaturized, the scope is also smaller. And there are transnasal endoscopes as well. Sometimes it can be rather more comfortable to place the tube through the nasal passages than over the tongue. It can cause less gagging. And the views on those sort of miniature transnasal scopes have also improved a lot. The biopsies that you get with them are rather small, so fine for a quick look, but not really good for monitoring Barrett's. But you're right, endoscopy is definitely improved from what it used to be. When they were first made, they were rigid scopes. Can you imagine that? It was a rigid tube, so it'd be really awful.
I'd rather not think about that. We did have one question in the chat saying, can you have a cytosponge test if you've had an endoscopy in the last 5 years?
Yes, so for the screening trial, we've just been working out how long ago it would be reasonable. And I can't remember if we decided 3 years or 5 years, to be honest, in the end. But if you can remember having it, then for the screening trial, we exclude you. 5 years is probably about on the cusp. But if you've got symptoms or you're having follow-up for Barrett's, then can be done again on case by case basis. But for screening, probably once in 5 years is about enough.
Fine, thanks. And then we can move on to some questions about diagnosis and the sort of symptoms that maybe should alert patients to the possibility that they're developing a tumour. Because the trouble is, you don't really think anything's changing, or you ignore small changes until it becomes really serious. But somebody asked, does the position of cancer in the esophagus cause different sorts of symptoms? And is it unusual to have a tumour at the lower end of the esophagus? And if so, does this position make diagnosis more difficult?
So actually, most of the cancers we see now are right at the junction with the stomach, or the gastroesophageal junction, and these are adenocarcinomas nearly always. So those are the commonest ones. Sometimes patients sort of say, point to where they feel the pain or the discomfort or the food sticking. That's not always a good indication of exactly where the cancer is. So you may get some feeling of whether it's higher up or lower down, but the esophagus doesn't have good nerve endings in that way that you perceive. So the most common symptoms are food sticking and losing weight. Pain less commonly until it's more advanced. hiccuping sometimes, pain on swallowing sometimes, but that can just be inflammation. But I'd say the key things are food sticking and losing weight. Now, really, we want to know about the problem before that. And that's hard because there aren't many symptoms about the heartburn. So, by the time you start getting food feeling sticking, it's already usually quite a narrowing or a lump. And that's because the esophagus is a muscle tube. So the muscle will be very effective at, even if there's a little lump in the way, it'll just contract hard and push the food past the lump, and you still won't realize there's a problem. So, it's inherent in the way that the esophagus is made to be so effective that sometimes it means that you don't know that there's really a problem until later on. But I would say if food is sticking, then that's a really important reason to go and get it checked out. It can just be, never really happened before, but the eating Sunday lunch, meat, piece of bread or something sticks, and then, it happened again. Go and get that checked out. So those are the common ones. There are other less common symptoms, but those are the things to be aware about.
There was a question from a speech therapist who said that they'd noticed that their voice changes are sometimes associated with esophageal cancer, and they wondered why.
Yes, that's usually because the vocal cords can be affected. Or lymph nodes can be near to the vocal cords, or the nerves that supply the vocal cords more commonly. So it's then affecting the the way that your nerves make you able you to phonate and make a sound. So these are more common with higher up tumours from squamous cell cancer. Can sometimes come from the lower adenocarcinomas, usually through lymph nodes. Very occasionally, the cancer can actually erode through the esophagus into the airway. And then that, of course, will affect breathing and the voice. But again, hopefully we can diagnose these things before their voice changes is very much the aim, but it can happen. The other thing that sometimes surgery and operation to treat the tumour can interfere with the vocal cords and the nerves around there. So that can also cause a voice change for a different reason after the treatment.
Fine. Well, thank you for that. I'm going to go to some questions that come from the chat now. So I don't know if you've had time to see these, but there's one saying, my son was diagnosed at age 31. Do you think this cancer is becoming commoner in young people? And a similar question coming up was, why set a lower age limit for recruitment? Because evidence seems to show that younger people are getting it. So,
I mean, what an awful thing when you get cancer at such a young age. So my sincere sympathy. So we are noticing cancers, colon particularly occurring in younger people. So there's Cancer Research UK actually have a grand challenge going on about what's causing cancer in younger people. And as in this example, we occasionally see esophageal cancer in younger people. It is uncommon. And so when you're designing screening programs, you have to, unfortunately, think not just about individuals, but about population, and about risk benefits, and about, the logistics, how you actually roll it out. And we've just been doing quite a big piece of work to take the results from our last trial and try and work out, if you take the population at large, what would be the trade-offs and the proportions within that population if you change the age and you screen younger people. To what extent would you have to screen a much larger number of people to find a smaller fraction with a cancer, compared to when you go to the older population, you have a much smaller reduced pool to screen, and then your yield is going to be higher because the risks are higher in that group. And so when you think about population screening, it's all about those risk benefit calculations. And that's why we have to, for practical reasons, and to avoid the downsides of screening, because, there are false positives that cause worry and anxiety, and occasionally a complication or a side effect from endoscopy. So you have to take all these things into account. So it is tricky. But if there are other factors increasing the risk, like a family history, then that's a special case. So the society guidelines, like the British Society Gastroenterology guidelines, if you have several risk factors in, then even if you're younger, you would benefit from you're recommended to have a screening test. And the other thing is to get the message out there about symptoms, and for GPs, even though it's very, very rare, if someone comes to see you and they've got food sticking, no matter how old they are or young they are, they need an investigation.
Yes, I went to a very interesting talk from a young person. I mean, he was a very fit, I think he was a gym trainer, and he had esophageal cancer, but it took a very long while to get that diagnosis because people just discounted the idea.
Exactly. So we do see that. I see that too in my practice. So I think that's an education message we really need to get out there.
And going back to the question of whether drugs can be a risk factor, there was a question about naproxen being taken for 10 years and amitriptyline.
Amitriptyline is an antidepressant. I'm not aware of any data on that. Naproxen is a non-steroidal anti-inflammatory drug. There's been a lot of interest in whether aspirin and other non-steroidal anti-inflammatory drugs, naproxen, ibuprofen, could actually reduce the risk of cancer of the esophagus. And there was a very big trial called the ASPECT trial, which looked at proton pump inhibitors with or without a non-steroidal anti-inflammatory drug. And overall, it's felt that it's not sufficient to recommend people taking aspirin in that case as a cancer preventative. Naproxen and all of those sorts of drugs are quite harsh on the stomach, so take them with a full stomach. And I think, there's no clear link to cancer. People have wanted to reduce cancer actually rather than cause it. I think with any of these drugs, take them if you need them. Be careful of the side effects, because especially these drugs that can be quite irritant on the upper GI tract. So we certainly see bleeding from non-steroidal anti-inflammatory drugs, for example.
Right. Well, this is a different question, but it says, is nivolumab? Yes.
They've all got terrible complicated names, haven't they?
If I say Nivolu monoclonal antibody, proves successful in after surgery treatment to prevent a recurrence of cancer. So if you've had surgery, is that a good treatment to have?
Yes. So it's very exciting that a lot of these drugs are now coming on stream for a number of cancers, including esophagus. The trials in esophagus are often sort of lag behind a bit other cancer types, but the trials are now coming on for esophageal cancer, and we particularly use them for more advanced stages or when it's coming back after cancer. And NICE are now licensing some of these agents. So it all depends on the particular details of the case, but they can be very helpful adjunct. And we now test routinely for people with advanced metastatic disease to see if they have a particular marker called PD-L1, which may make them more likely to respond to drugs like nivolumab.
Right, there's also a question saying, is there any special advice for those with a pharyngeal pouch taking these medicines?
Yeah, so pharyngeal pouch, your pharynx are quite high up near your voice box, and sometimes they can get a little kind of pouch in the side of the esophagus and things can go into the pouch. And we have to be very careful as endoscopists that we don't put our endoscope into the pouch and out through it and make a hole if we're not expecting the pouch there. So we're always very careful to look for these things. I mean, I think pharyngeal pouches can be a nuisance, as I say, because things will go into it. Haven't got any particular advice except to make sure that you're drinking plenty of water, sitting up well when you take medicines, yes, any of the medicines which are can cause inflammation and so on. Obviously, you don't want those really in a pharyngeal pouch. So something to discuss with your speech therapist if they got any particular tips or advice. It's not normally a big issue in my experience. If the pouch is really large, it can be repaired, and it's ENT surgeons that normally do that.
Right, and Another question is, what side effects does chemotherapy have on the bowel when treating cancer?
Yeah, this is a difficult one to answer because there are different sorts of chemotherapy. Particularly drugs like 5-fluorouracil can have toxicity on the bowel. So depending on the combination of drugs you have, then you may have side effects on the bowel, and it's something that the oncologists always try to monitor, and we try and change the regimes to reduce the risk of that as much as possible. There are a whole gamut of side effects from chemotherapy, depending on the combination that you have. The FLOT is the commonest drug regime we're using currently, and that's changed fairly recently, and the results are much more promising in terms of the efficacy of the chemotherapy, but it is quite a tough chemotherapy to get through. So yeah.
Oh, and I've got a question about inflammation, which so this is presumably inflammation of the esophagus. Can inflammation reduce and lessen over time if the factors causing it are taken away? Well, I guess that's what PPIs do.
Yeah, they do.
Extent.
So we see very good treatment with, these proton pump inhibitors. They're great drugs. And we see esophagitis, ulcers, and so on disappear. We always have to be careful that we're checking there is no cancer associated with that, because that won't go away. So sometimes if we see an ulcer, we always suspect a cancer until we've proven otherwise. But absolutely, if you reduce the cause for the inflammation, it usually heals up.
Right. And there's a question about throat mucus, which affects somebody's speech. But could the production of mucus be associated with Barrett's?
So mucus is secreted to try and sort of protect the lining of the esophagus, especially from acid, and there's a lot of mucus in the stomach. The goblet cells, which we find in Barrett's, do make some mucus. So sometimes people find that the acid coming up can be a bit mucousy. So that can be associated in that way.
Yes, I must say, in my experience, the production of mucus results from breathing in the acid. When you have a really bad acid reflux attack when you're asleep,
horrible.
That's the response to that is for lots and lots of mucus production.
Right, so that's probably the body's defense. Yes,
absolutely. It's pretty grim the day after. We've got a few minutes. Somebody did ask about diet, particularly about what sorts of recipes could be used in diet. That's a rather large area to go into, but and you've already talked about avoiding acidic foods, but it's quite hard to actually decide what foods affect you, because it seems to vary with every individual. And I would say you need to actually keep a record for a little while and see which things will stimulate acid production. But I think it's also partly your physiological state, because at my worst, just drinking a glass of water would be enough to produce an attack. Are there particular things that you should avoid?
Well, we've got another webinar coming up, haven't we, Liz?
Yes, I'm going to talk about that at the end.
So that will be, we're going to have a dietitian on that call, so that they will be really well placed to give some advice. I mean, the common sense thing is anything that makes your symptoms worse, avoid. It is slightly different for different people. There are particular foods which make the valve, the lower esophageal sphincter, kind of relax, and they are things to be avoided. A lot of people tell me pastry is particularly bad. I presume it's the fat content in pastry. Very acidic or spicy foods, caffeine and chocolate, I'm afraid, make the lower esophageal sphincter relax. But I wouldn't make your life miserable. So if you eat chocolate, it doesn't cause you any bother, then that's fine. But if you find it, if you have coffee and a nice piece of chocolate, it really upsets the symptoms, then avoid it.
And someone's just asked a question saying they have some question about long-term use of the omeprazole. I believe it is a tendency to lead to bone thinning, but it's a balance.
Yes, I mean, it's a balance. All these drugs have side effects. Proton pump inhibitors are some of the most commonly prescribed drugs worldwide, and we have decades of experience with them now. So I think we can be confident that although there are some side effects, that we're getting, they're pretty well known and they're pretty safe drugs by and large. But there are things to watch out for, including bone thinning. And so what you need to do is make sure you're taking the drugs for good reason, and then make sure you're doing other things to protect your bone health, including not smoking, taking regular exercise. If you need to be taking supplements like vitamin D, getting checked for osteoporosis and so on.
Right. There's a question just come in saying, I was diagnosed T4B after difficulty swallowing squamous cell, no family history. Could you have detected that earlier?
Yes, I mean, so I would hope that with these non-endoscopic tests, we could, just find both types of cancer early. If we were screening people at an older age, particularly people with risk factors like smoking in this case. Now, whether you would fall under the current kind of best 4 screening protocol we're coming up with, whether that would catch you in your circumstance, I don't know, because we are using medication for reflux as part of that. But I think this is, as our tools get better, then absolutely, and it's easier to test, then we should be able to diagnose more people earlier. More, unfortunately, it's unlikely we're going to be perfect with this, but I think we should be able to do a whole lot better than we're doing now, is one thing I can say, and we should be able to diagnose a much larger proportion at an earlier stage.
Thank you. There was one final question, which was, when will there be a cure for cancer? And I think this is a question for a whole webinar. So
I think it is, Liz, but just to end on a positive note, I mean, I was at a Cancer Research UK event the other day, and we were saying, such fantastic progress has been made. It's not a matter of curing all of cancer, but cervical cancer is now, WHO have said we're going to be able to eliminate cervical cancer because we know what the cause is. There's a virus, HPV, and we can vaccinate for it. So, that's one cancer which is going to be a thing of the past. And many cancers now, if we get them early enough, we can either eradicate them or turn them into a chronic disease. So, I think we should be optimistic that we're definitely making progress. And I would like to thank NIHR for their huge support of the work that myself and many others do in cancer, and Cancer Research UK, of course, and the charities that support us as well, including for education for people, because they're all part of what we're doing to try and make cancer a less dreadful thing that we're all at risk of.
Oh, thank you. Thank you, Rebecca. And thanks to everyone who provided the questions. I hope that people have found this both interesting and useful. And thanks are also due to our hosts, NIHR. And I'd like to remind you that you can learn more about current research and register to take part in studies on the Be Part of Research website. I checked it out this weekend and found that there were over 5,500 studies ongoing. It's well worth signing up for their news and research updates, even if you don't want to volunteer to take part in research. Thank you all very much for joining us tonight, and I wish you a very good evening. Good night.
Thank you, everyone. Thank you, Liz. Good night.